We get hundreds of questions. I know it will be very difficult to answer all of them. Maybe at this point, just because one of the questions keeps on popping up is, what about the problem of ventilators, and do you really use non-invasive ventilation as well, or is that something that you would not perform in these patients?
So for the two oxygen delivery devices that are also aerosol generating are both high flow nasal cannula. It's either called Vapotherm or Airvo or high flow from a different company. And then non-invasive ventilation, BiPAP and CPAP. And so we, as a hospital, have made a policy that we only get you low flow oxygen up to 6 liters. And if 6 liters is not enough to get you oxygenating better, we'll consider high flow very carefully. 30 liters max flow, we'll put a mask on your face that usually catches all the droplets that are coming out. Absolutely not using non-invasive ventilation. And this is becoming a problem now with patients who are DNR, who we're not going to put on a ventilator.
Jean-Jacques, what is your take?
Okay, at the beginning, we did exactly the same. In those patients who had a non-critical COVID pneumonia, they were hospitalized and without short of breath. And suddenly, they become short of breath and increase their respiratory rate. So at the beginning, we are trying non-invasive ventilation, high-flow nasal cannula. But in 99% of these patients, these non-invasive modes fail and the patient are intubated. So right now, knowing that the patient is COVID and worsening with short of breath and high respiratory rate, we intubate the patient because we know that 90% of these patients will be intubated. So delaying the time of intubation is risky.
Okay. Well, thanks for your comment here. One other question we're getting from Maria is, she says, "Dear Professor, I find it really crucial to make a PCR to each single patient who is going to be hospitalized because we can easily miss the oligosymptomatic." Coming back to the question we just discussed previously, maybe Jean-Jacques, what is your thoughts here?
We had several cases at the beginning where the symptoms had nothing to do with flu or with COVID pneumonia. And suddenly the patients worsened, had a respiratory failure, had to be intubated, and then they were tested and they were positive. So right now we are testing all patients entering the hospital.
Yeah, this is pretty much what we do at the Medical University as well. We test every patient that comes in. Before we go to the next patient, I just want to maybe pitch a question to you, because we have one that might also work quite well with the presentation. And the question from Jaime is, can ultrasound be used as a triage tool? I guess, of course, in many different situations, but also in the COVID situation. What is your take here?
What you can immediately do is, for example, as Dr. Ruby mentioned, that you rule out pneumonia and rule out the pleural effusion. So a patient can present with dyspnea and he can have other kind of problems, not only COVID-19. And if the patient doesn't seem too good and you see a pleural effusion and a corresponding consolidation, this patient might have a bacterial pneumonia. So you have to treat the pneumonia and you won't think probably initially about the COVID-19 infection. And what Dr. Ruby also mentioned previously is you can scan the anterior parts of the lung and see distribution of B lines and also the features of the pleural line. So if you see some or many small consolidations and many irregular distributed B lines, and you have a dyspneic patient with high fever, that is a patient who is more likely to be intubated in a later stage. Maybe also Dr. Ruby wants to comment on this one.
Yes. But let's say if you have a patient, a non-critical patient, without signs of respiratory failure, if you perform a lung ultrasound, you can see there's a subpleural consolidation from which are issued coalescent or spaced B lines. It's an early stage. But many of these patients will recover without deteriorating. And when they deteriorate, you have an invasion of the ultrasound pattern by coalescent B-line. Exactly like a pulmonary edema, hemodynamic pulmonary edema, but it is not. It is a high permeability type pulmonary edema related to the virus injury on the lung. And what is characteristic is that at this stage, the coalescent B-line is sometimes issued for multiple juxtapleural consultations. But then the B-lines invade the entire lung. This is a characteristic of all intubated patients due to COVID-19. This is very strange for me because I have seen RDS patients all my life. I've never seen such a uniform presentation in terms of lung ultrasound.
This is highly interesting. I think very, very valuable information. Maybe just to explain how we will proceed, we now have 9,500 people in the webinar. So I have an impression the longer we go, more people come. So what I thought is we would maybe extend a little bit and answer some of the questions which are coming in, because I think this is something that is really on the mind of many people. And before we go back to maybe Martin's question, I do want to answer, post a question to you, maybe Dr. Balil. What is the role of lung ultrasound in the patient who does not have severe critical symptoms with COVID infection? Does it play a role there? Could we actually use this technology to maybe diagnose or maybe even find those patients who have a little bit of a more progressive disease of COVID-19 than others?
So I don't think, and I think the other two on the group would agree with me as well, that I don't think lung ultrasound in itself can as a sole measure diagnose COVID-19 infections. I'm primarily using it in my practice, specifically on patients that I can't do CTs or chest x-rays on. I'm using the lung ultrasound as the only measure I can use to image the lungs. And it's more so I'm trying to gauge the amount of lung injury or the amount of lung involvement. The second thing you can use it for, which I'm also using it for, is to track these patients when they're in the ICU. So if someone has had a CT done already, they got admitted, they're positive for COVID, they're intubated, and we're restricting, echocardiographers to go in, restricting radiographers to go in. We're not getting any of the diagnostic imaging we usually use in an ICU to get the answers we need. Also, and to attest to what Dr. Ruby said, these bulky conventional standalone machines, they're not easy to get in and out of a room or even to clean and decontaminate well. So I think it comes down to your obviously clinical suspicion, the clinical history and the symptoms and the lab findings the patient has, and then as an adjunct to confirm a lot of the suspicions you have or to come up with newer ideas, using ultrasound is the way to go in taking care of these patients.
Yeah, I think a great point that you're making here, that obviously you cannot make the diagnosis of COVID-19 and that there are certain clinical situations which look very similar. But again, also interesting to hear that there are some very specific findings that we can use as well. First of all, I think to all of you who have maybe not so familiar with lung ultrasound or ultrasound in general, it's not such a difficult technique to learn. Yes, you need some practice, but you can all learn it. And like I mentioned, we'll have a tutorial. And of course, what was just presented was a fantastic overview. We have, I can almost not believe the number, 11,000 unique viewers in this webinar. And I think that we should use this opportunity to answer some of these burning questions out there. Many of them are actually on the topic of lung ultrasound, but many of them are general questions. One of the questions that came up several times was, what about the risk of getting lung fibrosis? Is that a problem that some patients might get lung fibrosis even if they do not have intensive care, if they don't land on intensive care unit, but even the moderate cases, maybe those who stay at home? Does anybody have any information here? Maybe I'll ask Balil, maybe you want to mention your experience, or what are your thoughts on this?
Yeah. So lung fibrosis from recurrent bacterial pneumonias has definitely been documented. But looking at the number of people who get the influenza infection, I'm not familiar with any data that tells me that a viral infection, whether treated or untreated, which we can talk about, would lead to any residual fibrosis in the lungs. Even the treatments that they've come up with in the U.S., we're looking at remdesivir, hydroxychloroquine, zinc, azithromycin. None of these have really shown any potential benefit in a clinical trial yet. In vitro studies have definitely shown some theoretical evidence that these may help, but I'm not necessarily sure that this virus would cause lung fibrosis. If it does, we'll find out in the future.
Thank you very much. I think from my experience, or at least what I've heard from some of the doctors who've treated, yes, they've seen cases of lung fibrosis, but the data will have to be looked at, especially after some months and years, because we do not know what will happen to some of these patients many weeks and years down the road. There is some data that shows that patients after COVID have impairment of lung function, but we'll have to see if that is something which will turn into a chronic problem or is something that will alleviate or will, of course, come back to normal after some weeks and months. There was a question out there, maybe I'll ask Martin that, since he's working with such patients. Is lung transplantation in COVID-19 an option?
The ISHLT guidelines actually recommend to not transplant anyone with an active infection. So if they were to receive a lung transplant, it would be after they had cleared their infection and had still required chronic oxygen therapy, or they're just not getting better from the illness that they had.
Yeah, I think that it's a very clear statement, and I would completely agree with that. In this situation, it's a little bit, I would say, a risky procedure. There's a question coming in about the whole issue of isolation and when can we get the people out of isolation again. And one of the questions is what should you do? What kind of test should you run? And what if a test is negative? Can you actually release the patient from isolation? This is a question from Samantha.
So all the patients we take are tested, and they have to be tested negatively. So we cannot risk to have a COVID patient combined with lung transplant patient. But if they are tested very early, we do isolate them for, depending if it is an immunosuppressed patient, it is now the guideline that we at least test again after 6 days after the last documented contact with a COVID positive patient. And if that is negative again, and always just the PCR, the patient can be, the isolation can be withdrawn.
Yes, I think that's it. It centers around the question of how long is someone infected, how long does still someone have virus load, and I think some of these questions are still open, but I guess you need a certain margin until you can really release these patients and of course not risk him from infecting someone else. Fadi is asking the question is why in the Middle East are there so few patients, or why? What is the reason? Is it the weather? Maybe, Bilal, maybe you since come from a state where it's rather hot in Texas. Can you kind of relate to that somehow?
I don't think it has anything to do with the weather. I might be wrong about this, but viruses survive in very extreme conditions as well. I think it's all got to do with how humans interact with each other in every space and where you travel from and where you go. I know I spent a lot of time in Dubai in the UAE growing up, and I still follow quite a bit of stuff over there. And the way they have shut down that country to limit exposure and spread of the virus is probably one of the most robust that I've seen so far.
Yeah, I definitely believe also that it is also a matter of how the country manages these patients. But the issue of temperature is a very important one, because there's always the hope that it's a seasonal problem in Europe, that soon, if spring finally comes, weather is starting to really get better, I must honestly say here, that it will also take the COVID-19 infection away. There are, at least in my knowledge, a few publications that show that, yes, temperature and the humidity of the air plays a role, but if it will be such a difference or if it really has the magnitude to alleviate the problem, we honestly do not know. We can only hope that it works, but as mentioned, since you have it in areas where it's rather hot, I would assume that it is not the only factor that plays a role.
So if you look at the flu virus, in the winters, the flu becomes a lot more of a problem, is because people isolate themselves into indoor spaces. We're a lot closer to each other. We try to avoid going out, and the spread of a flu virus is a lot easier to happen in a colder climate or environment. Where when you're in a hot environment, you're actually moving around a lot more, and that may have something to do with restricting the spread of the virus by us not being confined into smaller spaces.
There's a question that comes with respect to kidney function. We know that many patients have kidney function, and the question was if it is related to the viral infection itself, or is it a phenomenon in the sense of multi-organ failure, which is related to hypoxia? Maybe I'll ask Jean-Jacques, are you seeing patients?
At the admission of the patients, the viral quantitative analysis shows very high level. 7 days later, the viral quantitative analysis show very low levels. But despite of this, the patient does not improve or even worsens. So the idea we have is that at first the virus is making an injury to the lung, and very soon an inflammatory storm made of inflammatory cytokine is injuring the lung. So the kidney disease, the creatinine level is a marker of death. It predicts the death of the patient. It is clearly demonstrated in a Chinese paper. So very likely, acute kidney injury is related to the inflammatory storms rather than to the injury made by the virus itself.
Yeah. Thanks for your answer. Regarding the last question we discussed with respect to temperature, we got a comment from Tim, and he is from the Middle East, and he mentioned that the population is rather young in these countries, which might also play an important role. And of course, as you mentioned as well, that you have very strict isolation measures there. He does not believe that the temperature plays an important role. So thanks for your comment, Tim. I think this is also very important that you contribute out there to this discussion. One question that we get regarding to the heart is pretty much related also to what we just discussed with respect to the kidney, but I'd also like to have your take on this. Is what about the role of the heart? Is the heart an important factor in mortality? Because we do see data that shows that a lot of patients have a cardiac condition which is the cause of death. Is it a secondary problem? Do the patients have, again, viral myocarditis, or is it just because the people have multi-organ failure? Maybe I'll ask Bilal, maybe you can give me your point on this or your thoughts?
So there are very few reported cases of cardiomyopathy that are related to COVID-19, but it's rare, but it's definitely been seen. In my opinion, and been doing critical care for this long, being critically ill is the stress challenge you can take. If you have a bad heart and you get critically ill and you survive a critical illness without your heart getting injured, your heart, it tells me that a lot of things in your body are doing okay from a heart standpoint.
Stefan.
So people who are getting heart injury from a coronavirus infection, they probably already have underlying coronary artery disease, and this is how it's he's manifesting during the critical illness.
In the Wuhan cohort, the high sensitive troponin level at admission was predictive of mortality. And the change of the troponin level, the increase in the troponin level according to time, was a high predictor of mortality. So I would say that according to the data we have, it seems that the virus is injuring itself, the myocardium, because initially the troponin level is higher in patients who are going to die compared to those who are going to survive. So I think that the viral myocardiopathy is a real problem and a real injury resulting from the virus itself. But we need more data.
Yeah, I think there's, of course, the concern that we have vascular leakage, capillary leakage, just as we have it in the lung, also in the heart. And I've heard reports of myocardial swelling. Maybe this is related to the virus. All too early to say. Definitely patients who have a cardiac condition are at higher risk. And most likely it does affect the heart either indirectly through the cytokine storm or directly by the virus. We do not know. I guess these are some of the things that we hope to clarify. I know there's many burning questions. For those who are interested, there is a platform that we founded as well where we are trying to answer all the questions that we get from the webinars. It's an FAQ platform called Doc19. Just enter it on the internet, doc-19.com. You'll also find it on our main webpage, which I'll introduce to you just brief a little bit later. I just want to maybe just end with just a few comments that are very important. Of course, Jean-Jacques has a very important publication out there, which I do want to highlight. It's a publication in anesthesiology about lung ultrasound, and if you want to see his presentation, if you go to the second page of this publication, the link is actually provided on our webpage as well. You will see certain URLs which you can just click on, and you can download the presentation from Jean-Jacques as he presented it today. So I think very valuable information. You can get it from our downloadable PDF under the Q&A section of our webpage. So this is the webpage that I've been mentioning. It's just the same webpage that you're now in, except that it doesn't have the ending web at the end. It's the COVID-19. That's a webpage we founded where we will put all sorts of relevant information for healthcare professionals out there to combat the battle against COVID-19. We provide information, just mentioned the FAQs, but also lectures, and that's exactly also where you'll find the free lecture that we just produced jointly with Martin and with GE. I'll just give you a very short trailer that you see what the video looks like. And finally, I think I just want to mention a few things which are very important on my mind. Of course, condolence to all of those who were victims to the virus in the medical healthcare professionals. I mentioned already the president of the European Society of Cardiovascular Instruments, to his relatives and to his family, of course. We do hope that we can end this battle soon and that we do not see many more victims in the medical community. I can only say protect yourself. Try to, of course, obey to these measures that are so important. We'll try to add with some information on our webpage as well. And I think one maybe message to the healthcare providers that I do want to say is, and it's a statement from a colleague who is very strongly involved in the World Health Organization, and he was one of these people who were instrumental in fighting the battle against Ebola. And when he was asked what he thinks is one of the most important key learnings from the Ebola, it is be fast. And I think that's something that I do want to end. And I want to thank you out there for your, of course, support and for being with us, for watching this webinar. I want to thank every speaker that was with us today, from Paris to Dallas to Vienna, and of course to China, who supported us very much as well. Thanks again. Thanks Jean-Jacques, thanks Bilal, thanks Martin, and thanks to you again.